So next, we're going to move on to Dr. David Minion, who's a professor of surgery in the Division of Vascular Surgery. Dr. Minion received his undergraduate degree from Notre Dame and his medical degree from Indiana University School of Medicine, and then went on to do his residency at the University of Nebraska, followed by a vascular surgery fellowship at Case Western in Cleveland. And Dr. Minion is definitely known as an innovator in the department. Much of his research centers around endovascular disease, particularly in the aorta, and developing all sorts of novel scoring systems and multiple patent applications, and always thinking like an innovator. So Dr. Minion, I'm going to turn it over to you, and thank you again for presenting this morning.
Great. Actually, my invention is really not as sophisticated as the first. So my talk is actually more about the process of innovation than the innovation itself. But I don't have any typical disclosures, but this is intellectual property that I own, so I guess I have a financial interest in it. But it is about EVAR, which is, for those who don't know what EVAR is, the concept of EVAR is treating of aneurysms, and this right in here is an aneurysm. Can you see my mouse?
Yes.
Okay, great. And an EVAR device is basically an aligner device that gets deployed so that it starts in the normal aorta above the aneurysm and ends up in the normal aorta below the aneurysm in its cloth line, so it holds all the pressure inside of the device, and none of the pressure gets out to the aneurysm wall, and therefore prevents rupture. In infrarenal aneurysms, we like a neck length of approximately 15 millimeters. That's the normal aorta above the aneurysm and below the renal arteries. And in that, device placement is crucial, obviously. So if you have a disadvantaged neck, if you land a little bit low, you've got a lot of unused apposition. So you want to land these devices right at the renal artery, as in this picture right here. And it's really a game of millimeters. This was a study of 3,500 patients looking at neck length, and they found when we got 15 millimeters, we had a great long-term success rate of 97%. But when we got below that, we started dripping down into really kind of very poor long-term durability. And what we're talking about is proximal neck failure. So what we've lost seal here, this graft has flipped down a little bit, and you can see the contrast getting around the graft and into the aneurysm sac. This is one where it's really slipped down, and you can see that the aneurysm is no longer protective, and if you have proximal neck failure, then you can still rupture your aneurysm. Now, it's a two-edged sword, though, because over-aggressive positioning can have its complications as well. And this was an index case for me in my career. It was in 2003 when I was just a young boy. And I don't know how well it shows up on this, but I deployed this new graft called the excluder. And it was actually my 6th deployment. And you can see the top of the graft here, and you can see the left renal artery. And I've outlined the top of the graft a little bit better. And hopefully you can tell that that's a problem, because the top of the graft is now covering the left renal artery, which means that kidney is not going to survive unless I pull the graft down. The grafts do have anchors in place. I was able to pull it down without ripping the aorta, but it was a fairly harrowing experience. Now, let me give you a little more background on the device. I didn't invent the device, but this was the device at the time that I was using. And it's constrained by a wrap, a cloth fabric wrap. And the wrap is constrained by a string. The string opens similar to the string on a dog food bag. So you pull this string right here, and it opens the device, and you can see the wrap now that's fully open, and the device is fully open. The conventional wisdom at the time was to pull the string as fast as you can so the device would open quickly in the bloodstream so it wouldn't jump around. The competition for this graft always said, well, this is a pull and pray graft, and I didn't realize what they were talking about until this happened to me. And you have to think back, this was, again, harrowing, and you say, well, why did this happen? And part of it was, I didn't record the video at the time, but part of me was thinking, like, my gosh, wasn't it kind of the way I pulled the string that made the problem? And so I thought about it and I said, well, hey, it seems like a crazy epiphany, but it was epiphany at the time because no one else thought about it, but maybe I should just pull the string slower. So this is my next case, my very next case, a few months later, and I said, well, I'm just going to pull the string slower. Now the rep in the background is saying, Dr. Minion, pull the string, pull the. He's yelling at me, pull the string, pull the, because no one had pulled the string slower. He's like, what are you doing? Pull the string, pull the string, pull the string. You've got to pull the string. And I'm just watching this thing deploy, getting the angiogram, and he said, oh my God, that was perfect. So it was kind of a simple thing, but the process of an innovation starts by first asking questions. You got to include questions of the conventional wisdom, and you got to be observant. What's actually going on, and how do you fix that? Hold on a second. And we ended up, that was our first 6 graphs, we had problems, but our next 28 was dead on. We actually ended up publishing it, and this was probably the start of my career. And I think back that, gosh, I did tons of presentations all over the country about this deployment. My career really started because I came up with pull the string slower. I mean, it's almost absurd, but you really, in surgery, you just got to keep it simple, at least initially. But then you've got to be iterative, and that's when the iterative approach comes apart. So if you look back at this device design, the wrap has to be constrained to the long end. The string lines up, or the knob lines up with the string, and then the string, when you pull the string, it actually is going to flower towards the seam because you're opening up a seam. So it's going to flower in one direction. So if you can anticipate that tilt, because the renals obviously aren't always asymmetric, and use that to your advantage, you can now actually have an iterative improvement of the slow deploy. And you can see now I've pushing this device right where it needs to be. I've learned that I can actually move this device up and down. I got to move it up and down before it gets all the way out to the wall here, because the anchors are going to set in. But at that point, I can really actually land this thing dead on track just by making iterations and how my deployment device becomes. Now, iterative comes from not only being observant, but still asking questions. And this question was one that bothered me for a long time. I couldn't figure out the answer to it, but does anyone see, in being observant, does anyone see the problem with this picture other than the fact that I covered the renal artery? I mean, I guess there's no other videos where it's virtual, but the problem is the renal artery is still perfused, right? Why is that so? If I covered this, why does the renal artery still light up? And now if you look back at that, if you observe this, these slides, but it finally hit me after looking at this graph for months, like, oh, wait a second, the top of this graph is scalloped. And really, it was perfused because there was a perfusion through a scallop. So I probably didn't even have to pull this graph down. So you got to ask questions, not only of conventional wisdom, but of yourself. And then that led to new iterations, how maybe I can find additional seal zones if I line up the scallops. And if I line up the scallops and get an additional 4 millimeters of seal, I can now bring the short millimeter neck up into a 14 millimeter seal zone instead by this aggressive positioning and get close to what I need to do for long-term durability. And that's really what this is about. It's how my patent is ultimately about aligning these scallops to a renal vessel. And this is the endo-wedge technique. We've actually been doing it for years and have up to 14-year follow-up with no type 1A endoleaks, which is amazing because we're using short necks, which should have at least a 10% type 1A endoleak. But again, it's iterative. Now that I know that I can move the graft, now that I know how to deploy the graft, if I have to put a balloon in the renal artery, I can push up against that graft and actually intentionally cover the renal artery, but cover it with a scallop that's causing perfusion. And then there's new iterative processes. As the graft becomes deployable, now I can go from the leg and actually reconstrain it and fix my graft tilt and get the extra seal that I need. Now, the last process of innovation in surgery is you got to make it patentable. So to make it patentable, you either got to describe it as a treatment or you got to design a device. And one of the things, another epiphany that I realized is no one wants a scallop graft. And actually the graft there's actually not going to be any scallop grafts any longer. The one that we're using is on its way out. But PTFE is deflectable. You can actually change the properties of PTFE, how you design the nodes and fibrils to make it stiff or malleable or whatever. And this is a different graft, but the seal ring is down here. It has an anchor system, which is held on by very, very thin PTFE. This PTFE is not supposed to be for seal. It's just to hold on these anchors. But you notice it's so thin that it's deflectable. So if you can make part of the fabric deflectable, then you've got a new device design. And that's what really the patent is about. It's using this technique to put balloons in the renals. It's got a graft. This is just one of the many embodiments that has a graft that has deflectable fabric on top. In some embodiments, we have little devices that help us pull up the device. But ultimately, I think that's what you got to think. You got to think in terms of innovation, and then think in terms of how you're going to make a patentable design. And that's all for me.
Wow. Hey, quick question. Those balloons, they kind of serve as an anchor to get the scallop where you want them to position. Is that the concept?
Absolutely. Yeah, they are meant to force, as you push up, they're meant to force that scallop into the clock face, I guess, the orientation on in the tube, so that the scallop is lining up with the renal artery. But you can also use it as an anchor to affect graft tilt and move the graft to where you want it to be.
Fantastic. Thank you for your great presentation.